puzzle that the thoracic wall is bigger than thoracic cavity. Many times we spoke about it, you study anatomy primarily, you know that the diaphragm has an position. That is the cause why several organs of abdominal cavity protected by the ribs, because they are located below the diaphragm but behind of the ribs due to the high position. Uppermost point of your diaphragm can reach the level of the fifth rib during the deepest expiration. Understand what does it mean? Up to your nipple, approximately, you will have the diaphragm. But up to your knee, below your nipple, you have a huge amount of the bones. It is from 6 up to the 12 ribs. And of course, they will make the cage not only for thoracic organs, but for the abdominal organs. And what is located inside of the thoracic cavity? You know, there are two compartments from right and left side belong to the serous cavities. We call it the pleural sacs. Look, I don't call it pleural space, because pleural space, it is part of the pleural sac. It is not the whole sac. And between two pleural sacs, we have the fibrous space. If two previous is serous, it means they covered by endothelial cells. This one, it is this fibrous, it is covered by fascia, which we call endothoracic fascia. Previous time we discussed it, yeah? That is the layer which is covered the wall from inside. And that is the mediastinum, friends. Now, very quickly, not waste the time, let's speak about the pleural spaces again. That is not a big news for you, that sac contains two types of spaces. One we call pleural cavity, second we call pleural sinus. What does it mean, pleural cavity? If she will be lung, I will be the wall, I will be covered by parietal pleura, she will be covered by viscera. Distance between me and her will be called the pleural space. This space will be potential because it can be enlarged or vice versa, decreased according to how much she will be open, how much she will be expanded. Because if it is deep breathing, we can even touch to each other. If it is superficial breathing, the space between us will be big. Of course, you know that inside of this space we have small amount of the serous liquid. Of course, you know that this is not free liquid. What is the free liquid? Liquid which is descended and accumulated, and it is pathological condition. Our liquid just lubricated the surface. And by the way, speed of the absorption 5 times more than speed of the production. That's why this liquid cannot be anyhow accumulated. But of course, if there are pathological production, in case of inflammation, in case of the high transparency of the vessels, a huge amount of low oncotical pressure, high hydraulical pressure, there's a different kind of problem. Now look to me. Where is the sinuses and how they form? We understand what is the space, what is the pleural cavity now, where is the pleural sinus. It's very simple, guys. Transition of one parietal pleura into another parietal pleura forms the angles, which is called the sinuses. The much more better it can be shown in the transition between costal pleura and between the diaphragmatical, yeah? Because this is the most sharp angle and this is biggest sinus inside of the pleural sac. Along of middle axillary line, from the level of the 7 up to the level of the 10 ribs, it doesn't contain the lung tissue. That's why this is absolutely empty. I show for you the distance, which can be simply punctured without damaging of the lung. You must know that this is the lowest place of the pleural space. For example, in this picture, you can easily find this sinus. This is costal diaphragmatical. So you can see that lung doesn't reach this space. You can ask me why it is necessary to be here. It is a reserved space. If we need to have some more respiration, if the lung will be open more than normally, heart physical roles, work, stressory conditions, anything which is need more respiration, we can use this axillary volume, yeah, for the respiration. This is potential volume which can be used to expand more the lungs. But remember, please, even during the deepest breathing, lung doesn't occupy completely this space. Let's say this is more than enough for us. And of course, it will be free liquid. By the way, free liquid we call pleural effusion. Free liquid divided into two main types, the transudate and exudate. Transudate contains low proteins, and that is the microfiltration of our plasma. exudate vice versa. It contains high level of the proteins, and usually it is inflamed liquid. But anyhow, if there are free liquid, it will be accumulated in the lowest place of the sac, which is our costodiaphragmatical sinus. And you should make punctures, especially from this sinus, to make the evacuation of the liquid. After I will show it for you. There is another 3 sinuses, except this one. Second is located in transition between the costal and mediastinal anteriorly. Third one in costal and mediastinal posteriorly. And last one between the mediastinal and diaphragmatical transition. All another sinuses except the costodiaphragmatical doesn't have big meaning because they small and they cannot contain the free liquids for us. And this is not the big potential species. If it is understandable, I don't have time now to speak about borders. Everything is simple, guys. What does it mean? Borders of pleura. It is again transitional place between one part of parietal pleura to another. What does it mean? Anterior borders. Transition between costal and the mediastinal anterior. Posterior, it is transition between costal and mediastinal posterior. What does it mean inferior border? Transition between costal and diaphragmatical. What does it mean superior border? How high located the cupula of pleura from clavicle or first rib? Now look, then you look into the anterior border, you should understand that this is not symmetrical. Right and left borders is not symmetrical. Why? Because heart is pushed the left border to the left side. Right border doesn't have any influence, but left one is pushed. Can you come to me? Now stand up by the face to me. Now look what is happening. This is his anterior margin or border. This is posterior. Then heart pushed this anterior border. Posterior come to the medial. Anterior border pushed to the lateral side. But at the same time, posterior border come to the medial side. Thank you very much. Sit down. That is the cause why, for example, posterior border of the pleura located in the level of the body of the vertebra, but the right one pass strongly by costovertebral joints. Because then heart is pushed the anterior margin of the right pleura. Posterior margin come to the vertebra and cover it. Do you understand this? About the passage between the costal pleura and diaphragmatical, the more back you will go, the more downwards it will pass. If anteriorly this starts from the level of the 6 approximately rib, yeah? Posteriorly along the posterior axillary line, it is come to the level of 10, 11 ribs. Why? Because we have formation of the costodiaphragmatical sinus, which I say is the lowest place of the pleural side. About mediastinal, fibrous space. By the way, here you can see previously mentioned sinuses there. This is anterior costomediastinal sinus. You can see surgery cervical. And that is the costodiaphragmatical sinus. Yeah, part of the, you move from up to down. Let's say this is the mediastinal pleura. And this is the place of transition of mediastinal pleura into the diaphragmatical one. By the way, you can ask me now, you can say if the mediastinum covered anterior right and left borders of the, if the pleura covered the right and left borders of mediastinum, why mediastinum called the fibrous cavity? Simply because this pleura from inside completely covered by endothoracic fascia. Endothoracic fascia cover all these walls from inside, and the inner surface of sternum, and the inner surface of vertebra, and right and left mediastinal pleuras. So it forms completely serous cavity except upper border. Upper border open. It is communicated with neck region. Let's say connected spaces of the neck continues into the mediastinum. Because from upwards we don't have any bordering. Bless you. Is it understandable for you? Very well, let's continue. What the division of it? I told you last time, if I don't mistake, that we can make imaginary division, we can make anatomical division. Imaginary division is simple. You pay the angle of your sternum, you provide it horizontal plane, it goes to the disc between T4, T5, it is divided mediastinum into upper and into lower. How you make anatomical division? For example, during the section of the cadaver, you find bifurcation of the trachea, and immediately by upper margin of this bifurcation, again you provided a horizontal plane. They coincide with each other, of course, imaginary and anatomical. Above the plane, we have superior, below we have inferior. Superior, it is common space without division. Inferior is divided by pericardium into anterior, middle, and posterior. How you can remember the structures? Each compartment of mediastinum contains loose connecting or lymphatic nodes. Except it, there are 4 groups of the structures: arteries, veins, organs, and nerves. So let's make classification. What we have in superior mediastinum. From organs, 3 organs. Anteriorly, we have location of the thymus. Especially, it is important structure in the childhood because here we have the differentiation of the T lymphocytes. Yeah, they divide it into 3 main pools: T helpers, suppressors, and killers. Yeah, but after we see evolution of this organ, for example, my organ and your organs usually, yeah, it is presented by fat. Touch wood, if we will make, for example, CT scan and we'll see the big size of the thymus, it will show the thymoma, tumor of the thymus. Because for the child, it is approximately equal to the size of the pericardium. It is so active. After the 6, 7, it is become to the evolution, and in pubertans, and after this, it is absolutely involuted, and it is shown by piece of the fat. Which another organs? Trachea, esophagus. Of course, trachea. So look, I don't say the main bronchi because bronchi located in inferior mediastinum, not in the superior. You remember we make division by upper marginal with bifurcation. Arteries. Aortal arch with 3 branches. I think it's not necessary to know. Brachiocephalic, left common carotid, left cephalic. Veins, it is right and left brachiocephalic. They join to each other. They forms the superior caudal vein. Ductus thoracicus, like the venous structure, right lymphatic ducts. Yeah, they drain into the venous system. Yeah, and nerves, of course, descending branches. It is the vagus. It gives the recurrence branch, which goes outwards. We discussed it. Truncus sympathicus, nervus phrenicus. 3 structures. By the way, phrenicus will be located in front of the hilum of the lungs. Vagus will be behind. Truncus sympathicus will pass along the vertebra from 2 sides, right and left. That's all. Now we come to the inferior. Anterior portion doesn't contain anything except fat and lymphatics. Middle portion contains the heart with the biggest intrapericardial vessels together with the main bronchi. Because as I say, bronchi located inside of inferior. By the way, border between middle and posterior compartments will be passed by posterior border of pericardium and posterior surface of bifurcation of the kidney. So bifurcation will be involved in the middle mediastinum, not in the posterior one. Pericardiophrenic vessels, yeah, branches of the vagus nerve, which has come to the pericardium and make innervation. Now we come to posterior. From organs, it is only esophagus. From arteries, it is descending aorta with its branches, intercostal, yeah, which has come to here. From the nerves, it is the vagus, truncus sympathicus. That's all. Don't forget to mention here the azygos, hemiazygos, right side azygos, left side hemiazygos, hemizygos accessorius, which is drain the intercostal nerves. Azygos from right side, 6 upper left hemiazygos, accessorius 6 lower left hemiazygos. That's all. Now let's come to the surgery. I'm very sorry, guys, that I speak so fast because I don't have really time. And 1 minute attention from me. What about surgical access to the thorax? First of all, you must remember that surgery can be performed in the wall and in the cavity. Primary in the wall, we use the open access. In the cavity, we can use or open or minimally invasive access, which we call endoscopical. For example, the wall access we use for the treatment of the breast problems, for the treatment of the purulent problems, for the treatment for some congenital malformations. So we can make huge amount of the surgeries in the thorax. For example, if we will take only breast surgeries, it will be 100 different accesses. We make the total mastectomy, we make radical mastectomy, we make the simple mastectomy, lumpectomy, saving surgeries. This huge amount of the manipulation. Then we speak about the entrance into the cavity. Primary, we divide it into 2 main types. It is open access and the endoscopical, or we call minimally invasive. Endoscopical access divided into 2 main types. First one we call the mediastinoscopy. Second one we call thoracoscopy. Mediastinoscopy provided endoscope inside of the mediastinum, thoracoscopy inside of the pleural spaces, yeah, which we mentioned before. Now, 1 minute attention to me. Then we speak about open access surgery. All surgeries by open access divided into two main types: thoracotomical access and sternotomical access. You understand that thoracotomy will open the pleural sacs, sternotomy will open the mediastinum. By the way, we can use the combination between the thoracosternotomical access, which is open both these mentioned compartments. Of course, you can say, what about equipment? Yeah, we will need the special equipment, like artificial breathing system, artificial circulation system, because if you will open two pleural spaces, both lungs will be collapsed. And the normal breathing will be impossible. So you will use artificial breathing, of course. So you will need the machines. Now, thoracotomy in its turn divided into two main types. Technically, it is thoracotomy with resection of the rib, or ribs, and thoracotomy without the resection of the ribs. Now, imagine that these two, my friends, it is two ribs. One is high, second is low. If I enter into the thorax between them, and this size is enough for me for my performance, we call it thoracotomy without resection. If this aperture is not enough, especially for the adults, because in the childhood it can be enlarged because the ribs has the cartilaginous part, then it is not so simple because you will break the bones. So I can take one, or I can take both these ribs and remove. It will be thoracotomy with resection. You remember we make subperiosteal resection to not damage intercostal neurovascular bundles. Up to 3 ribs usually we remove. If we remove one rib, immediately your incision will pass strongly by midline of this rib. If you need to remove both ribs, you pass it strongly between them. If you remove 3 ribs, you make vertical incision. So remember, please, now, according to position of your thoracotomy, it is divided into 3 main types. Anterior lateral, access to the anterior and lateral surface. Just lateral, access to the lateral surface of the pleural sac. And posterior lateral, access to the posterior and lateral space. Usually position, if it is the average situation, not some special case, usually position it is along the 5th, 6th intercostal space. Why? To be in midpoint. Because in 5th, 6th intercostal space, approximately midpoint of our sac. Distance to upwards and distance to downwards is equal to each other. If you will make upper incision, you will reach only to apex. If you will make lower incision, you will reach only base. If it is necessary, do it. If no, you will make the middle incision to reach all the possible structures which is need to be reached. Anterior incision, usually you start between sternal parasternal line, maximally you enlarge it up to the middle axillary. Along this incision, you can reach the anterior surface, and what is important, you can reach the hilum of the lungs. For example, you need to make the ectomical surgery, pulmonectomy, or do, for example, the resection of some lobes of the lung. You need to have the root elements, of course. Ale czekać, nie? If it is the lateral one, it is shortest, by the way, smallest incision, usually along the axillary lines, yeah? From the anterior one up to the posterior one. It has one problem. You don't see the root, you don't see the elements. Usually you work in the lateral surface if there are some peripheral structure like the tumor, which should be removed from the lateral surface. Yeah, it's great. It is not so big, it's also traumatical. Consequently, we come to backside from the vertebral line, or you can say costovertebral joint, we come up to the level of the posterior axillary line, or middle axillary line. You open from backside and root of the lungs and posterior surface of the lung and lateral surface of the lung. This is, by the way, biggest incision. That's all about the thoracotomy. About sternotomy, guys. 2 possible sternotomies we can make. In majority of the cases, it is vertical sternotomy, strongly from midpoint. Usually, we use it to make the surgery in the heart. Open heart surgery, for example, CABG surgery. Yeah? You will open it, you will apply the special retractors, you will enlarge it up to the 15 centimeters, it can be enlarged. much more harder if you will make only horizontal incision, because in horizontal direction it is impossible to enlarge so much because ribs will fix it. That's why usually horizontal incision we combine with thoracotomy. For example, clamshell incision, it is the right and left anterior lateral in combination with horizontal sternotomy. You open all pleural and mediastinal compartments. For example, to make the transplantation of lungs and heart together by one complex. Let's say, or for example, there are the polytrauma of the thorax, and you must to make the revision of the right and left compartments together. Yeah. In three of them, yeah. I'll just after mention, or I didn't check it. Yeah, I will check it out. Let's say we can make this combination, let's say sternotomy together with thoracotomy to make this big access very traumatic. Unfortunately, in case of the polytrauma, you don't have another choice. Let's continue, my friends. Now I want to start to speak about the breast surgery. I cannot say that this is the most important problem in the breast surgery, but you can ask me why I start from it. Because guys, in the future you will have a huge amount of the subjects, like the oncology, which will discuss the special problems, or for example, endocrinology, which will discuss, for example, mastopathies, or oncology, which will discuss the breast cancers or benign tumors, malignant tumors. But I will speak about the inflammation, which is called the mastitis. Mastitis, it is inflammation of the breast, which is happening in two parts of your life. First one, it is lactation. Second one, it is the last trimester of the pregnancy. That is the time in which the breast is active and it is productive. What is the etiological cause of the problem? Usually Staphylococcus aureus, Streptococcus, different stamms. This is non-specific putreficated inflammation. And the risk factor, of course, I say it is the pregnancy, it is lactation. And executing factor, it is not enough drainage of the breast during the breastfeeding. That's it. You know, there are the rules. Then you make the feeding by one breast, it should become empty. Only after this you can use another breast for feeding. Yeah? Why? Because milk, it is great environment for the microbes. You understand that child is damaged the areolar nipple region, and if inside, of course, if you will not wash, if you will not clean, and before and after feeding, and if inside of the breast will be the milk, simply infection can be spread inside of this lipid, and simply greatly it will be environment for any microbe infection. But now I don't want to speak about so much etiology and pathogenesis because my subject primary surgically directed. I want to speak about localization of the pus, and of course I want to speak about the surgical performance to treat this problem. By the way, the problem is treated not only surgical. Again, you know, from one question another question is become, to answer in this question, pathologically we must remember, but pathophysiologically must much more better that inflammation has primary three stages. Stage one, it is catarrhal before formation of the pus. Stage number two, it is phlegmonous in the time of formation of the pus. And stage number three, of course, it is the gangrene or necrosis. That's it. Then you start your treatment in stage number one before formation of the pus. You can use the conservative treatment. But sorry, in last two stages, despite how much antibiotics you will use, you must make incision. There are surgical rules, guys. The pus should be drained and clean. Pus cannot be disappeared. Doesn't matter how much antibiotics you will give. Idea is understandable. So 1 minute attention into the picture. According to final location of the pus, we have 4 types of the mastitis. For type number 1, we call the subcutaneous mastitis. Maybe the most simple variant. For the lucky persons, this pus try to come to outside. What does it mean? It is perforated anterior wall of the capsule. It is come to fatty tissue, and it is accumulated under the fat. You can say why I call this person lucky. See if the fat pus will go to deep to inside, It will be much more sad. Situation number 2, pus again count way in front, but now it's accumulated in the region of areola and knee. Situation is much more dangerous because we know that here we have sinuses. And they can be simply, inside of the pus we have the proteolytic filaments, which can perforate it and damage any soft tissues. So if these ducts will be damaged, the lactation will be impossible, because that is the milk evacuational system. Why after some plastical reconstructions is forbidden to have lactation and feeding from the breast? Because the ducts can be damaged. And this physiological function will become impossible, or will give the heart complications, like the mastitis, which is shown. Localization number 3, that the pus doesn't want to leave the breast, then it is spreading inside of it. Instead to perforating the capsule, it is perforating the septus, which is divided lobes from each other. And from one lobe it is spreading to another lobe. And finally, position number 4, it is so-called retromammary abscess. Then it is perforating posterior wall of the capsule, and which goes inside of the retromammary space, between the space between the breast and between the muscles of the thorax. That's all. Now we must understand how problem is treated. I show several types of incisions. By the way, type number 1 and 2 we call radial incision. They have the form of the radices. That is best incision in the breast surgery because it is minimally damage the ducts and sinuses, which also have the radial direction. But we need attention to me. Let's start from the most simple type of the abscess, which is called subcutaneous. In case of so superficial location of the pus, evidence of inflammation is greatly visible for you because you see local signs of the inflammation. Dollar, coral, ruber, tumor, as everything is visible. In the place of the maximal tension, you take your scalpel and you make incision in which direction you want. Usually you try to do it maximally cosmetological, not so much visible, not so big. Why you don't use here the radial incision? Because you don't cut the tissue of the breast, you cut only skin. You don't cut the breast, again I tell you, you cut the skin. Because pus is located in fat, it means in front of the breast, not inside of it. You find the final destination of this pus. You clean it, you wash it, you do everything which is necessary. You even drain it. Is it enough? Of course, no. Why it is not enough? Because you will not be stupid. You will understand that pus is not originated in this fat. Pus become to this fat. If you are so clever that you treat the final destination, you must be enough clever to treat the first place of its origin. And first place of its origin will be not in the fat. It will be inside of the breast. So what should you do here? You must find the communication which is connecting this fat with the part of the breast. Because again, I tell you, problem is originated in the breast. That's why it is called mastitis. Usually by your finger, or usually using the probes, how you want, doesn't matter. You must find the communication between the fatty tissue and between the breast. What after? After the same what I say, clean, wash and drain. And don't forget, for example, here is some lobe of the breast, yeah? I must palpate it, two borders of it, which is formed by the septus. Because if this septa is perforated, it means I must to destroy it by my fingers, and I must enlarge the cavity of the pus. How much? To find the intact septus. If I find the intact, non-perforated septus, it means I find the borders of inflammation. But now there are big problems. You make beautiful, small, cosmetological incision, but after, by your fingers, you form the huge cavity inside of the breast. What do you think? Is it possible by this small incision to make complete drainage of this huge cavity? No. Forget about it. So what should I do? I have one incision. Yes or no? I must find the most far point of the cavity from my primary incision. I insert, for example, it is come up to here. I inserted my finger or probe, and I push this point from inside to outside. And by tip of my finger, I make second incision. Now my second incision should be strongly radial because I cut the tissue of the gland. Second incision we call counter aperture. Only in case of double incisions I can completely evaluate 100 times. So for example, let's take the bottle and perforate it. Can you remove all liquid by one aperture? That's impossible. Some liquid will come to out, negative pressure will be formed inside of the bottle, nothing else. Make second aperture. Air will enter by one aperture, liquid will go by another. Because you will have atmospheric pressure, not the negative. Approximately same you do in that case. You make the counter aperture. Now you can see I inserted the drainages in both these apertures, and in primary one and in counter one. Is it understandable? Brilliant, let's continue. Now let's imagine situation number 2. Pus is primarily located inside of the, by the way, if it is galactophoretes, all my steps will be same. But only one difference. First, your incision, we try to do between the border of pigmented and non-pigmented skin. That is great place because the scar is invisible. Then you make the incision in border between two colors. Usually it is disappear the scar. But you must be very, very careful to not damage the sinuses which is located just under the skin. So you bluntly separated the fat, you find the pus, then you find the portion of the breast with inflammation, and all previously mentioned manipulation which I do before. Now let's come to situation number 3. Pus is located immediately inside of the breast. Of course, I will start my incision by radial one. I will use ultrasound. I will localizate it, understand where is located the pus, and along with my ultrasound picture, immediately above it, I will make incision. I will enter inside of the gland. All another steps will be seen. If you will work along one lobe, you don't need to make the counter incision because size of your incision and size of your cavity will be equal to each other. If you will enlarge your cavity by the damage of the cells, of course you will make finally counter incision to make the adequate, let's call it adequate drainage of the space. Some special incision we do for the retromammary abscesses. Here we elevate the breast, we find the skin fold. Along the skin fold, we make semilunar incision, same like in case of the, for example, breast reconstructions. What we cut? Skin fat. Then we see the inferior margin of the capsule. We put the hook, we push it to up, we open the space which is behind of it. Inside of space, we localize it pus, we clean, we drain. Again, we find its communication with the breast. Again, we do everything which I mentioned before. Again, we make counter aperture. Again, we make the adequate drainage. Suturing, you understand, up to the drainage tubes. This is not the blunt closure of the wound, It is forbidden. If you will bluntly close the wound, pus will be continuous inside of the tissues and will kill the patient. Let's continue. Next problem, which I will quickly introduce for you, it is the liquid. X-ray, which show for you the liquid inside of the raised post-diaphragmatical sinus. The classical sign of the hydrothorax, it is horizontal, otherwise we call cut it lung level. So you see, like we take the knife and horizontally cut it the lung tissue. Why it's so? Because we have dense X-ray negative structure, which is liquid. Liquid doesn't show in the X-ray. So you don't see free sinus as in this case, You see just the cutted surface. Same problem by ultrasound. But now the position is not horizontal, not vertical, it is horizontal. There's inside of postomediastinal sinus in the posterior wall, You can see accumulation of the liquid. Same picture, but by CT scan. Now you can see accumulation again of the liquid inside of the posterior wall. Again, position is horizontal. Doesn't matter which method you will use, you identify the liquid and you decided what to do. Primary treatment included two main elements. Element number 1, surgical evacuation of the liquid. Element number 2, treatment of the main problem to prevent formation of the new liquids. I don't know what is the main problem. metabolical disorders, traumas, oncological problems, what is given. But anyhow, it should be treated, otherwise you will make forever this puncture. Puncture can be performed by single time, puncture can be performed by some long-term period, yeah. If it is single time, you use the single needle injector, yeah, and you make the puncture and remove it. If you make a long-term puncture, you will use the drainage tubes. It is valvular drainage tube, it works only in one direction, from inside to outside. From outside to inside, air doesn't enter, otherwise pneumothorax will be. Best place of the puncture, look to me, it is between your posterior axillary and scapular lines along the 7-8 intercostal space. Point number 1, it is the dislocation of the skin. Point number 2, it is the lemon peel formation. Point number 3, puncture. Point number 4, then you fall down the needle into empty space, you finish your puncture, you start to evacuate the liquid. Approximately 3 centimeters is enough for the normal constructional person to reach the pleural space. To be attentive here, because if you will insert your needle more, in right side diaphragm with liver will be perforated, in left side diaphragm with spleen will be perforated. In both cases, internal bleeding. Let's continue. Now we come to puncture technique. You palpated the upper margin of the lower rib, and along the upper margin of the lower rib, perpendicular to the skin, by step of 0.5 centimeter, by injection before any step of 2-3 milliliter of the solution, I don't know, what do you want? You inserted your needle. And what is the main rule? Don't evacuate more than 1 liter of the liquid during one puncture, otherwise it can form the collapse. Dislocation of the mediastinum quickly in the side of the puncture will make the collapse syncope and the person eventually die. That's all. A Larray point we use for the puncture of the pericardial cavity. You understand that in case of pericarditis, in rheumatical fever, yeah, we can have accumulation of liquid inside of the pericardium. You must remember the Larray point. Look here, please. This is my xiphoid process. That is my left costal arch. Apex of the angle between these two structures we call Larray point, and we use it for the puncture of the pericardium. But what is important? Primary, you apply your needle perpendicularly to the skin. Again, lemon peel, again 0.5 point your puncture step. And what is important? Approximately 3 centimeters, then your needle is entering into the tissues, you perforated the rectus muscle with its sheath. Let's say in front of your rectus will be the transverse fascia and parietal layer of peritoneum. In that time, guys, look here please, from perpendicular, you change position to the ascending. And sliding by the inner wall of the thorax, sliding to the costal left arch, you push your needle from down to upwards. It is immediately perforated the diaphragm, and it is become to the inferior sinus of the pericardium. How you can understand it? Your needle starts to pulsate. If you feel the pulsation of your instruments, it means you reach your destination, and you start to make the puncture or evacuation of it. Very, very quickly, let's come to the last topic from this PPT. That is the pneumothorax. If I will translate this term from Latin, it will be air inside of the thoracic cavity. Etiologically, there are 2 main forms of the pneumothorax. First, we call spontaneous. Second, we call traumatical. This means spontaneous, meaning tension, without trauma. There are some problem of the lung tissue. I don't speak about the wall. Lung tissue is ruptured and respiratory system connected with pleural cavity. Air from respiratory system enter immediately inside of the pleural space. It is increase the pressure and it makes the collapse of the lung. By the way, this pneumothorax, which we call spontaneous, divided into 2 types, primary and secondary. Primary, it is congenital disorders. For example, connected with the synthesis of the surfactant. Yeah? with formation of subpleural blebs. Secondary, it is the putreficated processes of the lung, like tuberculosis, which I showed you before. Yeah, for example, this is the subpleural bleb, this is the tuberculosis. Huge caverna, you can see inside, huge cavity. Of course, pus finally will perforate the cavity, and we will have combination of two problems. Hydra, pneumothorax. And pus with the blood, and air in the same time will be entering inside of the pleural space. You understand me?
Yes.
How you will identify? In X-ray, you will see something like this. Look. Look. By the way, this is the negative X-ray. Positive one show bones in white color, negative is black color. But anyhow, what do you see in left side? Complete collapse of the lung. You see, lung is pressed to the root. Space is empty compared with the opposite side. But in the same time, if it will be with hydrothorax inferiorly, you will see horizontal level of the window. So both sides, you will see together. What does it mean? Traumatical pneumothorax. I think you understand there are trauma. By the way, trauma can damage and the wall and the lung. Imagine blast waves, for example. It is rupture from your respiratory system by the high pressure. It is ruptured the lung tissue. But final result will be same. Doesn't matter air will come from immediately environment or from respiratory pathways. It will make the collapse of the lung with the formation of the pneumothorax. By the way, pathophysiologically, by the mechanism of formation, all pneumothorax is split into three main types: closed, open, and tangent, or valve form of the pneumothorax. What does mean closed? Now somebody will open my door, then door will be closed. Once air will enter in my room, then communication will be closed. God knows how much air will be entering. But usually it will not give the complete collapse because pressure will be higher than atmosphere, lower than atmosphere, but higher than normal. Is it understandable for you? What does this open pneumothorax for? Open window. We have communication between the environment and between the pleural space. What is the valvular? One-sided defect. Do you remember 2 minutes before I speak about the one-sided drainage tube? No, one-sided defect. During inspiration, valve is open, air is entered. During expiration, it doesn't leave. Finally, what is happened? Not only collapse of the lung in the side of the trauma, but the opposite side and heart is collapsed. They pressed also. They said, look, any pneumothorax can kill us. Primary, because not of sign of the pneumothorax, primary by bleeding. But pneumothorax by itself, if it is one-sided, can kill us only if it is tangent. If it is not tangent and one lung will not work, sorry, we have second lung. Do you understand? Yes. Why tensional will kill us? So simply because heart will be pressed together with the opposite side. That is the problem. What can I do? Simply, if it is closed one, make puncture, remove the air. Puncture place, it is middle clavicular line, first, second intercostal space. Why here? Because here pleural cavity is wide, because lung forms the apex, it's that small. Air goes to up, here I make the puncture, here I remove the air. In case of open one, 2 steps. Firstly, close defect. Usually we apply 3 layers of the suture of the wall. On the pleura with endothoracic fascia, on the own layers, and finally on the sliding layers, several layers. And then make puncture and remove air. In case of the tangent one, 3 steps. Like emergency treatment, it is puncture of the pleural cavity, fistula. Now air will not come, but will leave. Because environmental air will be lower than the pressure inside of the space. Then close defect, then make puncture. Let's say for closed 1 step, for open double step, for tension 3 steps. I don't want to give you upper extremity today, but I will tell you your marks.